Welcome to Beyond the Battlefield, a SIMVR conversation on military, veteran, and family health. This series brings together researchers, organizational representatives, policymakers, healthcare providers, and people with lived experience to discuss a broad range of topics relative to military, veteran, and family health from a variety of perspectives. I am Dr. Nicholas Held, the Interim Scientific Director of SIMVR, and today I am joined by a great group to speak to us about traumatic brain injury. To start, I'm going to turn to each of you to introduce yourselves to the listeners, including who you are and what perspective or perspectives you are representing today. Sid, can I start with you, please?
Thank you, Nick. Of course, I'm Dr. Sid Kershane. I'm a veteran of the Canadian Armed Forces. I did 30 years in the military. I am now the Chief Medical Officer at Veterans Affairs Canada, and I'll be talking about how we entitle veterans for injuries.
That's great. Thank you very much, and thanks for being here. Excited to have you. Marcus, I'll go around my screen to you next.
Yeah, my name is Marcus Baseman. I'm a former head of rehabilitation medicine at the Canadian Armed Forces. The certificate says 37 years. That's with a bunch of reserve time where I didn't actually know I was on the PRL list, but apparently I was. I'm the co-owner and a clinical lead of Beechwood Physical Medicine, a veterans-focused rehabilitation clinic that involves multidisciplinary care. Amongst others, we see a number of veterans, more and more it seems, with traumatic brain injuries, and particularly repetitive subconcussive blast injuries and special forces folks. I've known Trevor basically since his injury, just about, and have been fortunate to connect with a lot of the scientists and the clinicians that have shown me through Trevor that nothing is impossible when it comes to the brain. And that would be ultimately the message for today, is that this is a new frontier, I think, and there's been no time in history, I think there's been more hopeful to be in the realm of neuroscience and clinical neuroscience than now.
Thanks, Marcus. That's a great kickoff, and that highlights some of the pieces we'll be talking about today that I can't wait to get to. Isabel, can I have you go next, please?
Sure. I'm Isabelle Boileau. I'm a senior scientist at the Center for Addiction and Mental Health in Toronto. I'm also a professor of psychiatry, and my focus of work is in molecular imaging. So I'm interested in brain health in general, but more recently in the brain health of military people that have been exposed to low-level military blast.
Fantastic. Thanks, Isabel. And last on the call, but absolutely not least, Trevor, I'll have you go next, please, and thanks for being here.
It's Trevor Green. I'm an Afghan war veteran. I suffered a traumatic brain injury 20 years ago from a axe attack when the Taliban ambushed my platoon.
That's great, Trevor. And we know how much you have to offer and the incredible journey you've been on. So thanks so much for being here today with us. And thanks to all of you to being with us today. I'm going to kick off the first question, and I'm really excited to see where it goes. And this kind of bounces off as you brought on, Marcus, when you first mentioned. So traumatic brain injury, the focus of today, will often be referring to that obviously as TBI. It's been getting a lot of attention lately. And I think it's probably safe to say that this is not necessarily a new kind of diagnosis or experience for the Canadian Armed Forces members and veterans. And it's probably been around for quite some time, or at least aspects of it that we've been understanding or coming to understand today. So, Sid, I just want to turn to you and ask if you can provide any information on kind of the history of TBI, or how long have we been hearing about this?
Thanks, Nick. Yes, traumatic brain injury is not something new, and I was reintroduced to the concept of shell shock recently when I had to do some research for a talk I was giving to a military medicine audience. And I wanted to talk to them about the evolution of the table of disabilities since World War I. And I found the original table of disabilities. But in reading on the history of the table of disabilities and the evolution, I came across the familiar expression of shell shock. And it was interesting because it came from the French. And the French call this le vent du projectile, which means blast. It's a nice way of saying blast. The French language is more poetic than other languages we know. But the definition of shell shock was not what we usually see. It was actually described as pressure and decompression forces on the brain. And I thought, well, that's traumatic brain injury. But then for some reasons unknown, the medical community sort of focused more um, on the aspects of the emotional aspects of trauma. And they went down and you look at the evolution of the DSM and all that, and there's no more mention of traumatic brain injury. But if I go back to the original Table of Disabilities of 1917, we were compensating veterans for loss of skull by the square inch. So the more square inches, yeah, it was actually measured by square inch of loss of skull and with an equivalent entitlement. And I thought, well, why would the medical community compensate for loss of skull and ignore any injury to the brain itself and totally attribute what was wrong with veterans to what they called at the time neurosis? So they told soldier, you're just being neurotic. Get over yourself and get back there. And there was a resistance to entitlement. So I'm thinking we need to go back, going back and looking at the history. There was some truth there in history that we failed to follow through on. And fast forward to the year 2020, and we're approached by the special forces and their medical team saying, our breachers and our snipers are demonstrating some symptoms that we can't really explain. And through work with groups like Isabel's group and the medical community and people like Marcus and all that, came back to the realization that these military service people were being exposed to low-level blasts at Marcus, and that it was causing these symptoms. So there's a regain of interest now in this, and that's why we're starting to look at the evidence, the science, but also listening to the veterans telling us it's more than PTSD. It's also my traumatic brain injury. And Trevor mentioned it. We started seeing that in Afghanistan. We knew that people were coming with symptoms of TBI and symptoms of PTSD, but these are two different pathologies and need different approaches.
That's great, Sid. Thanks for that overview, and I appreciate that. So what are these symptoms that we're seeing with TBI? And he's mentioned that they are different than PTSD, and I think that's a really important thing, right? Is that recognizing that these symptoms are different. What symptoms are we seeing? And then I guess a follow-up question that can open up conversation is there a way to detect any of this or looking at this prior to symptoms really setting in? And that doesn't have to be directed at Sid. Sorry, I'll turn that to anyone who wants to jump in, of course.
Yeah, well, I was going to say, well, maybe Marcus can address that.
Yeah, I really appreciate that in terms of the introduction, because I think the language of the day seems to predicate how we see things. And I think what we saw in the US, for instance, is that TBI became the signature injury of the conflict in the Middle East to the detriment of anyone acknowledging that there's mental health issues, because it seemed to them that the organic pathology was in some ways more palatable than PTSD. I think Canada early on took another slant where everything became PTSD. And as Dr. Courchain mentioned, the veterans themselves were saying, yeah, but mine does not feel like classical PTSD. Right? And then there's lots been written about this polytrauma triad, which almost universally comprises the patients I see. And the triad is often combined with some mental health diagnosis, be it PTSD or depression, some form of TBI, and some form of chronic pain. And when you look at the Venn diagram of all those symptoms, there's symptom overlap with all of them, right? Where things are subtly different is in the realm of subtle things like vestibular and visual issues and other balance issues. And we can dive into that more or less. But where people were missing the boat, I think, are some of the more subtle features that now that we're doing better assessments for TBI, we're picking up on things that, if mitigated early on, might have preempted someone from losing their career. And as a quick example, there was a veteran from my former regiment, 12 RBC, that was the regimental sergeant major who'd had so much blast exposure. I think his blast gauge, which they weren't using all the time, had registered higher count than any other veteran. And he couldn't get out of the tank after firing a number of rounds a few times, but as a good RSM, would not tell his troops and say, look, boys, I just need a little bit of time. When we finally saw him as he was transitioning, it came apparent that his visual system was the most impacted by this, and that his job as an RSM, and probably the chief of forces or chief warrant officer for the entire forces, would have been staring at the computer all day and then driving home and doing the same in reverse. So in other words, his visual system was overly taxed. And getting him into neurooptometry, which is another form of therapy that's just recently regaining some ground, is changing his perspective and perception on his injury drastically. In other words, his cognitive testing was fine, his EEG recordings were fine, everything else was fine, but his visual system was severely taxed. And that's what I would leave people with is, if you've seen one concussion, you've seen one concussion. They all seem to present with subtly different symptoms and a constellation of signs, and not looking for the appropriate signs and symptoms means we're missing the opportunity to intervene at the right time.
I can speak to what Sid just said. I was on my second weekend of my tour. I was blown up by a roadside bomb, and it cracked my vertebrae, my lumbar vertebrae, and broke my leg. And weakened my leg. So that it broke when I got home. And I've got chronic pain all over my body. And when I have PTSD episodes, the chronic pain seems to increase. I'm not sure why. I guess it's maybe sensory overload. I'm not sure.
That's
Yeah, go ahead, Sid.
interesting. I'd like to perhaps, this is something else that we've heard from veterans. And Marcus, we're sort of told to be patient-centric, to listen to our patients. And I think we still have a lot to learn in that area. We need to listen. And I remember being in a group of women veterans who were complaining, who were telling us, I am more broken after I release. And I was released with a diagnosis of PTSD and completely paralyzed with pain. And so I challenged my group at Veterans Affairs. I said, is there a relationship here between fibromyalgia and PTSD? And they did a fantastic job, because they came back in short order and they said, there absolutely is. There is science that shows that if you've got PTSD, you are more likely to develop chronic pain. And when they look at people with chronic pain, there's a high percentage of them who do meet the criteria for PTSD. So based on that, we changed our entitlements. We created an entitlement for fibromyalgia, so that if people, because they don't release with the pain, it takes a while. So if within 2 years of releasing, you develop any of this chronic pain and all that, it will be attributed to your service if you were diagnosed with PTSD. So I think you were right with your triad, Marcus, to point that out, is that all of these are related. But I want to go back to the TBI and the PTSD and the difference between the approach in the US and us. I do remember when I was still in the service and we were screening people for traumatic brain injury, when we asked our US colleagues and counterparts, how they treated, how they differentiated the TBI symptoms from the PTSD, they told us, oh, well, there's none. We consider it all the same. And when we asked, well, how do you treat it? They said, well, we just treat it the same as a PTSD. And I think what we've been hearing from our veterans since, that they're very dissatisfied with that because they keep telling us, it's not my PTSD symptoms that are bothering me. It's my traumatic brain injury symptoms. And up until recently, we didn't have much to offer, but I think I'll let my other colleagues talk because I think we are learning more, and there are some advances in that field that are very interesting and promising for these people suffering from this.
Yeah, and I want to add something here. I find it strange that PTSD symptoms can be attributed to TBI per se, because if TBI of course occurs in other areas, concussion in athletes, for example, who don't often exhibit signs of PTSD, which tells you that, and I know, of course, the mechanism of blunt trauma versus blast trauma is different, but to confound PTSD with symptoms of TBI seems, at this day and age, a little bit, strange. And I really appreciated what, your history of the diagnosis, because it tells us how very recent our understanding of the symptoms of TBI, how recent this all is. And, in terms of the development of the science behind it, we're still in such early days to try to understand what's happening physiologically. TBI, again, if we can define it, I think it's easy to diagnose if it's a TBI, a moderate or severe TBI. What's harder to understand what's happening scientifically is the mild TBI, the repetitive mild TBIs that don't have clinical symptoms, that can be diagnosed with classical imaging approaches. And this is where I think the work scientifically lies. What is actually happening in brain, so that we can identify the mechanism and go back and try to find ways to rehabilitate the brain after these injuries that are not seen by classical imaging approaches.
I fully agree. And just to loop back on what Trevor mentioned, and I'd love to hear more about Trevor's perspective, is that there are such things as painful memories, literally, when it comes to PTSD. And there's Dr. Solomon, I believe his name, in Queens, who's doing research specifically on that topic. And the notion that, exactly as you said, Trevor, when you go through that phase of reactivation of the PTSD, the hypervigilance just amplifies whatever signal comes in, and pain being just one other signal, it's no doubt going to be amplified. And what we're seeing, interesting with the portable EEG system we have in the clinic, is that most veterans with PTSD, but also chronic pain, have one of the markers. It's the P300, which is just one of the evoked potentials we can measure, that seems to be off the scales as far as its sensitivity. And it's like taking the volume knob on our brain and ramping it up. And I think that's the simplest thing I could say to anyone who's listening, is if you look at the things that cause you grief in life, you can ramp them up or ramp them down. And we could talk later as to what those strategies might be. But the underlying condition is bad enough. What makes it worse is the comorbid or concurrent issues that sometimes cause that volume knob to get ramped way up.
Yeah. And I guess one way to chat about this right now that might be important is you just mentioned, Isabel, the classifications of TBI. I'd be interested specifically in a military context of what mechanisms are related to TBI. So there's these low-level blasts, there's regular equipment use, there's other forces of combat and higher and actually blunt force trauma. Can we go over some of these key pieces? And then it's actually really interesting listening to you chat, because Trevor brought up this idea of an emotional response to the pain, and then we have a biopsychosocial aspect of intervention. And Marcus, you just highlighted this piece, depending on how the TBI occurs, how that might happen. If it's in a traumatic experience in combat, that's very different than low-level rifle shooting in a continuous way. So that I imagine that intervention would have to be different, because you could have elements of PTSD overlying it or other reoccurring thoughts or fears or whatever it might be. So it is not just saying we need to treat TBI, but really putting in some thought into how do we classify these from a military context and what would that might mean for intervention as well.
Hmm. I mean, yes and no, to be very succinct in the answer. But again, looping back to Trevor, and I've always said, and I hope you don't mind, Trevor, but I've used your photo so many times in talks that were meant to be inspirational for people that I said, look, if Trevor's brain can recover 20 years out from the most severe survivable, from what I understand, head injury that NATO experienced in all those 20 years, then I think anything's possible. But what was particular in your situation, please correct me if I'm wrong, Trevor, is what we now call in the psychedelic arena set and setting. In other words, your personal factors and your environmental factors. Your lovely wife who advocated for you when I think none of us in the medical system really believed that this was possible. So back to basics, I think before we talk about nuances of how to treat specific TBIs, there's the basic building blocks, which means where this falls into the family, the person involved, their attitudes, the people around them, their access to care. That is all really predicating on how they're going to do. And I think that's critical to mention. And also the basic lifestyle medicine pillars of nutrition, exercise, sleep, substance use, stress, and making sure you have social community. Those 6 pillars need to be absolutely solid before we even talk about sort of nuanced treatment protocols. And I think we often miss the boat when we don't go back to basics. Did I get anything wrong, Trevor, about um, Debbie was, I think, the key piece in all this, and I've said
Yeah,
that,
she was right from the start.
and that is the piece that we cannot in medicine prescribe or
No,
substitute.
no. She stuck with me through thick and thin.
Well, so maybe that's something that you can comment on, Trevor, too, is not the specific kind of rehab protocols per se, but what elements of your recovery do you think were most important to the success that you've exhibited to this point?
Mm. I think Debbie being constantly by my side.
Hmm.
I went to a brain injury facility in Alberta, and Debbie and my young daughter came with me, and they were instrumental because that's when the horrific PTSD episode started, right out of the blue. That's when I tried to commit suicide. And only the thought of my daughter finding me stopped me in time. So I think it's invaluable and it can't be measured. The impact of family. Family is literally medicine, as Marcus says.
Mm. Thank you so much for sharing that, Trevor. Yeah, I couldn't agree more. And that's part of this biopsychosocial spiritual lens, right? That I think I mean, outside of TBI, I think we need to put this into many more cases, but it's not the idea, the theory behind it, I think is well founded. I think in practice, sometimes it can be challenging of how we actually integrate care in that way. And then those external factors like family around you, I think is as you mentioned, Trevor, incredibly, incredibly important. Is is there any mechanisms for support from that? From a like I'm looking at you, Sid, from a Veterans Affairs lens, but I mean just to facilitate opportunities for family to be engaged in these in recovery. I know it's out of the goodwill of their heart, and especially Debbie as is one of the nicest people I've ever talked to and able to support Trevor, but that's not always the case, I imagine, from a logistical standpoint too.
Yeah, and it's an excellent perspective. Um, we, of course, we're not there at the beginning of the treatment, of the care. We're there to support after. But we have to remember that the veterans that we serve come with their family.
Mhm.
And it's a bit of a contentious point because it's not written in the law that that's a responsibility, but I think it's an evolution. It's an evolution of thinking in even in traditional medicine, in that we're used to treating individuals and not taking into account all of their family support, their social support. And so we do have certain programs that are focused at caregivers. So I think of Trevor and the important role that his family played. So we've developed over the year a caregiver benefit. Might not be up to what is ideal, but it was something that was introduced from interacting with veterans' family, telling us, look, I'm the principal care supporter for my spouse or for their child, and even in society, caregivers aren't given that much recognition. And a lot of it is done, is that there's no remuneration for being a close caregiver. So it's something I think we need to think more about. We go as far as we can in supporting family members, including them in if it's their mental health services that they receive, to include family members, children, spouses. And I can't undermine the role. We have the Atlas Institute for Veterans and Families that have done a lot of work, because they're a center of excellence that was established outside of the department. They've done tremendous work with families, family members, and developing services, supports, specifically aimed at family members. And I do want to give a little shout out to our peer support organization that we run with our Canadian Armed Forces. We call it OSIS. And they've established peer support groups specifically for children of military and veterans, and for families also. So we have family peer support members. So there are areas in our programming that take into account the important role that the family plays in the reestablishment of veterans.
Thanks, Sid, for that overview again. And yeah, and I didn't mean to kind of turn it to the contentious only financial aspect of it, but just this kind of logistical pathway. And then it makes me think for clinicians, right? Like I can't imagine many clinicians if Trevor says, "Can Debbie come with me?" that they're going to say no. But I wonder if we think about if we're starting to learn the role of support members in healthcare, is it really on the medical professionals to turn to the veteran or to turn to any member of society to say, we would love for your family to be here if possible because of the role we know they play in your care. And maybe that's kind of forward thinking to practice as well, is advocating for them to be a part of it as they see fit too.
And I bet you that if you studied it, you would probably see health impacts on the brain. I mean, rehabilitating the brain is something probably very complicated, but if you approach it with a nurturing attitude, sometimes it's like these simple organic things that might really be the reason why people do better. We think about all sorts of fancy approaches to rehabilitate the brain, but in the end, it could just be, loving members that really make the difference, right? And that there's probably something we can track there as well.
And further to that, I'm in touch with a lot of guys from the platoon. We were ambushed after the attack. The axe attack on me was a signal for an ambush from the village. And Rob Dolson was covering my left flank, and he made an incredible shot and took out this guy, the attacker, as he was lifting for a second strike. He was pulling the axe out of my head like he would pull it out like a log. And Rob shot him twice, a miraculous shot. And then at the field hospital, one of Marcus's nurses named Maria Strepa convinced the medevac crew, the American medevac crew, that I would die if they had left me there because they took one look at me and said I wouldn't survive. So if those people hadn't been in that place at that time, I'd be dead. And I keep in touch with them as well as I can. And that's important. And I check in with them from time to time for how they're managing their OSI.
Hmm. Yeah, thanks for sharing that again, Trevor. And that's important for you, and I can only imagine how important that is for them too to stay in contact with you, right? This has been touched on a little bit, and Marcus, you touched on it, and you talked about the recovery that Trevor has made and how it might not have been expected in trying to traditional kind of medicine in a sense, right? But there's other factors there that have allowed Trevor to be here today to chat with us and to share all of his information, and that brings up the idea of kind of neuroplasticity. And we talked about this of how we're at the height of it's almost excitement to be working in this area with what we're learning. Can we touch a little bit on neuroplasticity? I know we have Trevor as a living example of it, which is amazing. So I'd love to hear Trevor's thoughts too, but just turning over to anyone to talk about the concept.
Yeah, so I think this dovetails nicely with what Trevor was talking about of neural networks kind of being a reflection in my mind of social networks. We now know from the natural world that underground there's this rhizomal network that connects literally everything to everything in nature. And without getting too far in the deep end of the spiritual side, what Trevor's talking about and what was mentioned a bunch of times of people's energies and their presence helping heal or being catalysts towards healing, I think is kind of the segue towards what we're seeing now on the neuroplasticity front. So in other words, I've stopped telling people that this is as good as it gets. And Trevor, you've been the inspiration for me to stop saying that because I was taught differently way back when I did my traumatic brain injury rotations in '94. Where essentially we said this is maximum medical recovery. This is as good as you're going to get. Rehab is done after 6 months, and good luck for the rest of your life. And what we've seen, and thanks to the scientists and the clinicians that didn't give up on you, Trevor, I'm thinking of the surgeon that did your heel cord lengthening. I forget the name that he used to do work in Africa for kids that had club foot.
Dr. Penny
Yeah,
was,
really. Nobody wanted to touch your feet, to be honest, from what I heard, but he did. And thanks to him, you're walking, right? So there's one other element of the neural network that kind of worked. And I know I'm getting ahead of myself in terms of those much broader networks. But in a sense, what I was taught 40 years ago in med school was that we're hardwired, much like a house or a car, and that if you break neural networks, they're gone forever, and that neurogenesis is not a thing. Now we know that's all hogwash, and that you can literally regenerate in ways that Trevor's shown us transcend everything we know about neuroanatomy and neurophysiology. And so what helps that regeneration is multifactorial. And this is where I'd love to get Isabel's take on certain things that we know in terms of neuroinflammation and why blast-related concussion might be separate from traumatic injury due to a single event is that neurons do have the capacity to reconnect. And as the saying goes, neurons that fire together wire together. And so those repeated loops that we use for better or worse to relearn activities or the mantras we rehearse, in some case for our detriment, can be rewired in the sense of being more functional. And the wonderful thing about that is that there are multiple simple things that can be done. We were talking about red light therapy the other day, about, again, nutritional supplements, nutraceuticals, and not even to mention psychedelics or transcranial magnetic stimulation or direct current brain stimulation, neurofeedback. The gamut of offerings is expanding probably faster than those neural networks are, which also puts us in a difficult position is who's who in the zoo, who's trying to make money off of these veterans, who has a legitimate offering, even though the science might not yet be keeping pace, right? And that's where I've been really fortunate to work with a physiotherapist that Trevor knows well, Tanya Yardley, who uh,
yeah.
who works with the Brain Innovations Network, which is trying to precisely separate the wheat from the chaff in terms of where is the best, if not scientific evidence, the clinical related evidence to what instruments are actually showing benefit, and do we need to wait for the double randomized controlled trials to occur before we start implementing them? But I'd love to hear more from Isabel in that regard as well.
Yeah, well, as far as I understand it, there aren't any, of course, approved approaches to, rehabilitate from MTBIs or repetitive head impacts. But I also like to listen to the participants that come to our research studies, and sometimes their intuition about how to get better is often very telling. How the brain wires when we first do that, when we're infants, is by simple interactions, by again, interactions with the mother. So again, to go back to the importance of having loving caregivers, I think that's probably the right approach towards brain rehabilitation. Outside of that, there's a whole bunch, like you said, a whole bunch of therapies that have been moved forward to be able to facilitate, synaptic, reconnections. Ketamine has been one, and there's a whole bunch of others, but they still have to be tried. Neuromodulation would, assisted with pharmacotherapies, might help retrain circuits, but there's, I think, no better way to do it organically, because that's how the brain is wired in the first place. Sid, you mentioned, of course, being in nature. Being in nature has tremendous benefits, and it's not for no reason. I'm pretty sure that the brain knows what to do when it's in nature, and yeah, maybe it's as simple as that.
I might, Nick, just based on the discussion here, again, I reflect back on experience with, in medicine, and also in seeing what's been tried in our veterans and all that. And sometimes we try things without exactly understanding what is going on. And this is where this year my curiosity towards brain health is more challenged, because for a while we were going back again to our specific veteran population that have PTSD because of their experiences and deployments. And then on top of that, they get a traumatic brain injury from exposure to an explosive device. And very often in our mental health clinics, we will see a certain percentage that don't respond to the usual treatments that we know that work, because we have good research on cognitive behavioral therapy and PTSD and all that. But we have a subgroup that don't respond. And we've introduced some innovative treatments. And in psychiatry, people know about EMDR, eye movement desensitization and reprogramming. I might not get it right. You might have to edit that part out. I'm not getting my acronyms right. But anyway, EMDR. We know it works. And we've added, and you're familiar with this, Marcus, with the 3MDR, which is and it's an evolution of the Karen, because now it's a smaller, it's a normal size treadmill. It's still an immersive environment. And we're doing EMDR while individuals are walking. And they've had really, really good results in those that have not responded to traditional treatment. And it made me wonder, so all of a sudden we hear about, in one specific treatment session, there's like a light goes on, there's like a breakthrough. There's like a breakthrough that happens. And knowing what I know today, I'm wondering, you mentioned neuro-ophthalmology, Marcus, and we know that very often those exposed to either low-level blasts or blast injuries have difficulty with their vision. And so my question and my questioning is there something to do with the eyes, that as we're training the eyes, there's some rewiring going on at the brain level that all of a sudden that settles, and then there's an opening or more responsiveness to the cognitive behavioral therapy. And so I think for me, that's a question I would like to push, because we see this rather than labeling these people as chronic PTSD, chronic this. I think we need to push more what is going on at the brain level. And, we have people like Isabel, thankfully, that can do that type of research to go and see what is going on at the molecular level and the structural level. I can only see the outcomes, but it does lead me to question, the eyes, the brain, they're all connected. There's something going on in these circuits here that we need to push
Yeah, and
the research in this area.
there are definitely studies that could be done to kind of clarify that. And I think, we've skirted around this idea of like some people respond, some people don't respond. One concussion is not equal to the other concussion. And this is where some of the, imaging tools or other types of tool might really come in handy. Like if you really want to do a trial to find out what approaches people benefit from, you have to be able to assign them to the treatment that they may respond to. So you have to understand what's happening, what explains the symptoms. If part of their deficit and part of their memory issue has something to do with eyes or an injury that occurs there, then of course the treatment has to be approached with that knowledge. In terms of brain imaging tools, of course, at the moment, we don't have the brain imaging tools that tell us what is happening. We can rule out a certain number of things, but like I said initially, there's no classical imaging approach that can diagnose the brain injury of people with repetitive head injury. We have a sense that there are markers of inflammation in the brain that show that inflammation is increased. There are also markers that show that the blood-brain barrier is not functioning well, and that might explain also some of these behavioral, pain, and as it relates to PTSD symptoms that Trevor, you were mentioning early on, that might have something to do with blood-brain barrier integrity that's not functioning very well, so that the effects are really systemic. And of course, I mean, what we're trying to do at the Center for Addiction and Mental Health is develop tools that would tell us whether a person might develop chronic traumatic encephalopathy as the result of being exposed to low-level military blast, which is something that we don't quite know at the moment.
You mentioned measuring the brain, Isabel. Quite a few years ago, a neuroscientist named Brian Darcy contacted me about doing a study using a functional MRI, and it was astounding. The results, he could show me after a few tries, he could show me exactly where in my brain was rewiring, was recovering. And apparently the healthy parts of the brain take over for the damaged parts. And he was able to show me a map of my brain with a colored, like a red colored, where the neurons were actually regrowing.
That's fantastic.
And he could specify exactly what it controlled in my body.
Yeah, I'm not an expert in that, but I know there's also people that are do neural feedback so that you can, in real time, see neural activity, and the person in the scanner, of course, is engaged in trying as much as possible to activate brain areas. In the same way, for example, you would try to control your heart rate by looking at, your heartbeat. You would do the same type of exercise to try to control neural function. I don't know how that might work in brain rehabilitation, but I think it's a neat idea to see what's happening, and get control over it. Yeah.
Isabel, I know one of your passions, Isabel, or one of your work lines of work is making the invisible visible, right? That's something
Right.
that we've chatted about. So, Trevor, that was kind of an opportunity for you to see this map of your brain. What did that, why was that important to you? Like as somebody going through, why was that so impactful? Just it was the visual of seeing something happening, or
Exactly, exactly. I could see it happening. It was an abstract concept because I could see it on the MRI results.
yeah, so that's so interesting, right? Like we know from a scientific standpoint, we talk about neurons that fire together, wire together, but that's very abstract. Where Trevor, this for you, somebody who's in a challenging time, a challenging recovery and road ahead, seeing that what you're doing is making a difference, not even necessarily related to the outcomes, but this actual kind of physiological piece is so inspiring.
I think that was
Yeah, for sure. It's motivating.
Yeah.
pivotal moment for many of us, that 2016 talk at SIMVAR in Vancouver, I believe it was, where Dr. Ryan Darcy presented those findings. And I think that followed by the TED talk that many of you have seen, I believe it's called Iron Soldier, that describes Trevor's journey, but also the recovery phase. And I think that should be must seeing, if you want to use the term, for any veteran that is disbelieving that the sky truly is the limit. And back to Isabel's comment about CTE, and thank you for bringing that onto the table. So certainly we've actually had some VAC reports come back where, and I'm sure this is exceptional, where the patient was diagnosed with CTE as a diagnosis on the chart, which is a pathological diagnosis. So
Yeah.
we're happy that they've extended it so far as saying TBI is recognized, but that CTE should be recognized in living people was a little bit of a surprise on our side. But the one thing I would really love people to remember, other than these extreme catastrophic cases like Trevor's exemplifying, which again is inspiring for us to know what can still recover, the vast majority of patients I see come in, their single biggest fear is that they will develop CTE. And yet everyone's seen the movie Concussion. Everyone knows what the potential consequences are. The percentage in my clinical experience of people that actually end up there, not that I necessarily get the privilege of seeing them for their lifetime, is relatively small. And
Yeah.
we know it doesn't affect everyone. And if there's one piece of level A evidence, because we have very little evidence when it comes to TBI, but the one piece of level A evidence, and Sean Marshall, my good colleague who helped us develop the guidelines for TBI rehabilitation with the Ontario Neurotrauma Foundation, basically said reassurance, as with most things in medicine, that most things can and do get better. To what extent they get better might be up for grabs, but that things do get better is the single most important thing we can do. So to have that discussion, and I know people have left their brains to the Concussion Legacy Foundation and other really well-intentioned places to study the pathology, which is important, but it's not helpful to that member. So I think that's where I just like to throw a little bit of a wrench into the discussion, saying the things that might be scientifically helpful may be clinically detrimental in this particular question.
Yeah, I fully agree with you. First of all, making a diagnosis of CTE in life is not something that's actually possible. I mean, CTE by definition is a disease that's marked by deposition of tau in brain that can't be really assessed in life at the moment. And you're right to say that the rate of occurrence of true CTE, if you're looking at postmortem examination, is less than 4%. And this is a very small percentage compared to, for example, collision sport athletes, NFL players, that I think the rate there was close to 90% in professional football players. So that just tells you. However, even if it's not marked by tau deposition in brain, I think the pathologists would tell you that there are other very clear indication that the brain has been injured. It's injured by blast, but it might not be related to the deposition of this toxic protein tau. So there's still so much work to do to try to understand what explains the symptomatology, because the symptomatology is real. So what explains that? You know, people blame axonal injuries, inflammation, blood-brain barrier issues. Um,
Which again, and I don't dismiss any of the importance of the scientific or basic science, but for the patient, the only question I ask myself lately is, how is this going to help? How is this helpful? And particularly since we're talking about the mind-body connection and neurogenesis and neuroplasticity, you know, neurons that fire together wire together. So there's more and more evidence that we literally become what we think of most. And if we keep mentioning things, I think the fact that we're asking every little kid that plays hockey, are you sure you didn't get this? Are you sure? I think we're creating a neurosis around an illness, if it's even
Yeah.
considered that, that didn't exist when I was young and played hockey without a helmet. And my neighbor, who's now a PhD mathematician, got knocked out with a hockey puck to the forehead, fell to the ice, hit his head, and was back on the next game. Now, that's extreme, but I think we can also send the pendulum the other way, where we worry people that should not be worried with facts that are not helpful for them. And I would just convey to everyone, be very careful of digesting too much information in this arena unless it's really going to help you.
Yeah, I agree fully.
Yeah, and I think it's probably a good segue into talking about new advances, about giving hope also to people who have suffered, severe brain injury. And Trevor, you mentioned seeing pictures of your brain. And so it brings me back to a presentation I saw recently. And it was a football player, was an American football player, but came to talk about his career as a football player, the number of concussions he suffered, and the brain imaging that he had as a consequence of that was really, as a clinician, looking at that, thinking it's surprising that this person can stand and talk in front of an audience. And but there are some new technologies, and you mentioned red light therapy. So he's been using what in scientific terms we call photobiomodulation, and showed some improvement in his brain imaging. Like it was his brain, it wasn't anybody else's brain, and there were some improvements, but that correlated with improvements in his life, in his irritability, in his vision problems, his what he qualified as brain fogginess and things like that. There were significant improvements. Again, we don't quite know what's at play, but I think it gives hope to people that if they do have serious injuries, that there are some new modalities that are coming to give people hope that there's a recovery is possible, and it's not enough to say, well, this is the best you'll ever be. You have to be like this. Um, there is, thankfully, scientists like Isabel that do research that brings new light and new treatments and hope in this area.
I'm not going to pass that you said new light, and that was a very clever quick.
Pun unintended.
Yeah. Trevor, I know a little bit about the work you've done from a recovery standpoint. Is there any emerging technologies or interventions that you've tried, or things like what did you find really? I asked you actually outside of the interventions, and you mentioned Debbie and the family support. But what about interventions that you tried, exoskeletons or Ryan Darcy's work that you talked about that you found particularly helpful?
Um, I, I I found uh, a device called a locomat that
Yokomat, yep.
connects robotic legs to my legs, and that was really helpful.
Mm.
Yeah,
Yeah.
and I'm trying psychedelic drugs now, and it's too early to tell if it helps, but
Some people have found that's associated with, sprouting of little new synapses. So,
oh yeah,
that's out in the literature, and there's ways to look at it with molecular imaging. Yeah, psilocybins associated with,
yeah,
new synapses.
yeah,
So maybe it's a bit of a help for brain rehabilitation. I don't know if that's the
yeah,
intent.
yeah,
That was the intended
hopefully,
use, but
yeah. And I take CBD regularly, and that helps with my anxiety,
Okay.
which helps with my physical health.
So that's another area that, there's been lots of trials, but nothing, again, nothing that has brought CBD forward as an approved therapeutic. But again, I think it's no harm in trying.
Yeah, there's a lot emerging in the area, and I mean, it sets us up perfectly for a conversation 2.0 in the future, right? Where we know that there's going to be a lot that's emerging, which is great. We've talked today so far, and I know we're getting close to time, although I could keep this conversation going for a long time. Actually, I've really enjoyed it. But we've talked before about kind of the symptoms earlier today, and we've talked about kind of the rehabilitation of it from a biopsychosocial spiritual lens. Now, I'm wondering about if we're looking at those in service. And we're looking at, and actually, when I was originally writing this question, I actually hadn't considered Marcus's point that he just mentioned about those that fire together, wire together, and having too much information and concerns around that as well. But is there anything? So we did see the UK Ministry of Defense come out and say that there's a potential that their own equipment is actually causing traumatic brain injury within their troops. So when we're talking about a low-level blast from rifles, we're talking about breaching and all this work within operations. What do we have for detection so that we're not only relying on symptoms that might be kind of delaying intervention? And this, I don't think anyone has the answer to this, but is there anything within operations with new technologies, ultra realistic simulations, anything where we're looking at how can we, because I know there is a dose response Isabel that we've chatted about, how can we assess this? Is there anything predictive to saying certain thresholds or certain amounts that will more likely lead to TBI? Or how can we kind of change operations to not only be looking at symptoms down the road?
I mean, they're measuring the impact of blast or on, the biomechanical aspect of it. So of course, there's preclinical models that look at, forces that are applied to the brain, and that's, so what happens to the brain when it's exposed to X force versus this force versus that force. So that gives you a bit of an idea of the range, and then, of course, prospectively, you can measure the impact on brain inflammation and other aspect of the injury. I don't know in the human. I don't know in the human what can be done other than, and of course, when you go to the human, it becomes messy because there's so many other factors, environmental factors, inter-individual differences. You can't really isolate. So you have to turn to the preclinical model, which I think is less than perfect, but yeah.
If I can jump in, I think, if we know that Newfoundland sacrificed more than any province in Canada, I'd be presumptuous for me to say that Canada tries to punch above its weight in NATO countries overall. And so when you look at training programs, what I've been fed back, and I'm not a policymaker in that regard, from our special forces folks that do a lot of breaching and breaching instruction, firing 50 caliber weapons, firing large rounds in artillery, as well as in motorized tanks and so forth and so forth. We seem to go above and beyond what might be reasonable and necessary. Other countries have already instigated, limits on how much you can fire. And even though blast gauges are being used, I'm not sure if they're universally being used, that once you reach a certain threshold, just like I used to work in a nuclear facility at Chalk River when I was a student, and at the end of the summer, I had a radioactive gauge, and if you were over a certain limit by a certain time, you did not step foot on that reactor again. And I think those kind of things would make sense. But what's frustrating, I think, from the soldiers I've talked to is that they know how we could mitigate this. They've written the papers, they've brought it up to the highest levels. And yet some of the old school folks, as traditionally is done, say, no, we've always done it this way. We're going to keep doing it this way. So in other words, I think we have the science, we have the well-meaning of some senior leaders. We even have some orders that are coming down, and somehow at the coalface, whether it's our training in Saint Jean or whether it's our combat engineers in Gagetown, are still doing it old school because I had to do this, so suck it up, Buttercup. You're going to do it the same way. And that's how we are actually hurting ourselves internally. And that I hear way too often. So to me, that's unforgivable that we could have something that we could prevent that we're not preventing for no other reason than stubbornness and adherence to old school mentality. And I think that's where things have to change.
Yeah, we don't know what the minimum amount of exposure is too, right? So like, how do you scale it back to the point that it's safe? I have no idea how that's done. Yeah.
Yeah, it sort of reminds me of medical school, Marcus, when you're giving your examples there. But I think you've hit the nail on the head there with training, because I remember in 2020 when we went to the Special Forces unit to have a roundtable with clinicians and researchers and some of the members of the Special Forces. This is something I've seen in other areas in the forces where the training is where people are vulnerable and at risk. And the more you expose them to the training, and it's defining what is just enough exposure to develop that skill. And I think that's why in aviation, they couldn't afford to lose people to crashes because they're not skilled enough and they developed simulators. And I think, exposing people to blasts, even in a training scenario, even if it's with less charges, still puts people at risk. And you're absolutely right. And the people who experiences do have some solutions. And I think, the leadership is should be listening to some of these recommendations, because we know that training is an area where people get injured more than in actual operations.
Do you think it's a question of age? So like, could it be that if you would expose people at a later age, like later than 25, when the brain has, in theory, finished its myelination, do you think that you might have better outcomes? I mean, we have very recent data in which we track over time changes in the brain in a cohort of youth at CAMH, and we are finding that synapses, of course, are getting pruned late into 25 years old. So if we try to limit exposure during this period of development still, would we have better outcomes? So they, of course, these are the same guidelines that you do with cannabis exposure or alcohol. So is there an age where blast is maybe less damaging?
Well, that's a question for you, Isabel.
There you go. Yeah, there you go. We're gonna have to. Yeah,
That's an
I'd have to go to the preclinical model. I wouldn't find myself. I mean, I don't know what's the age range in the during training. Are people like 19 to 25? Or are they?
No, listen, people join the forces now in their 50s.
Okay.
Yeah.
but probably not to become a special forces operator at that age. And
No.
what I would say is very interesting you bring that up, Isabel, because we talk about that a long time. But I was told when I was going to med school that your frontal lobes as a male didn't connect at least until you were 19. Now I understand it's like 29. Now either something's changed or we didn't have the right science. But if it's the frontal lobes that inhibit the stupid things that we do that get injured in the first place, then it's kind of a catch-22 situation. You couldn't get people that are older, although we do have many people that volunteer to do this stuff we ask these guys to do because their brains are connected, if that makes any sense.
Yeah.
It's a double-edged sword.
Yeah.
Well, I am mindful of the time, and again, I don't want to stop this conversation, unfortunately, but mindful of the time and everyone's schedules, and I really want to thank each and every one of you for being here. But first, I just want to turn it over. Is there any points that you wanted to bring up in closing that we didn't talk about today that you think is really important to mention?
Well,
Well,
I
maybe it's
just
more
want to
research.
say from our, from a Veterans Affairs Canada perspective, we have developed new entitlement guidelines for service members that are exposed to either, whether it's blunt force trauma or whether it's subconcussive forces. We're recognizing that, and we're continuing to work with our colleagues in the CAF and with scientists like Isabel and her partners to continue to deepen our knowledge on traumatic brain injury and looking at emerging treatments for that. I think that's very important for our veterans to know.
Thanks.
And thanks for the opportunity to participate today.
Of course. No, Simver's very lucky, and the listeners are very lucky to have all of you here. So thank you very much for your time
I'd
and
like to say there's, just as my colleagues on this panel, there are lots of smart, compassionate people doing a lot of work into this field of study. So I would encourage anybody with a brain injury, as Marcus mentioned, to not be confined. And there's no time limit on recovery from brain injury.
Mhm.
Beautifully said, Trevor. And start with the basics. I think we do have a quest, and the mantra that the Special Forces use is "we will find a way," and it gets in the way sometimes because sometimes you can try too hard. And I'm finding that when the mission is "I will get better at all cost," and I'm not even talking about financial cost, it actually sometimes gets in the way of doing the simple things that we could all be doing, those lifestyle medicine things, the tribe, connecting with social networks. I think those are as important, as we've said, as any of the fancy stuff. Not that they're excluding them, but we need to start with the basics and really get that down pat first.
Yeah. Yeah.
That's perfect. I think that's a good wrap up point. Ties into so many other areas, doesn't Marcus, as well, in terms of you look at transition, you look at community involvement and sense of belonging and purpose in life and all of these pieces. So that summary point that you just brought up ties to so many areas that we'll continue to talk about and have conversations about. So once again, thank you to each of you for being here today and providing your experience and your expertise to the community. It was a great conversation. I'm privileged to be a part of it. So thank you so much.
You're
Thanks for
welcome.
having
Thank you
me.
all.
Thank you.
Thanks.